get the pain and the complications. And the other one is the right needle position for each procedure. So I'm going to take you this morning through all the major procedures to a point that you all feel like you've got it. And as we go along, hopefully I will find some volunteers for different for some of the different procedures. The other thing I would like you to get this morning is a very good understanding of how, when you see a patient who presents with a certain problem, how do you determine what the hell to do with him? I mean, are you gonna, when he comes in, are you gonna do the tonsils, or are you gonna inject the area where he hurts or where he's ill, or are you gonna use your pendulum, or what? I talked yesterday night to a few people, and there is a lot of confusion of how do you get from your clinical diagnosis to what you actually do. And I hope I'm going to be able to present that to you in a way that you can make it work in your practice. I've been practicing neurotherapy since 1976, since I took my first course. Neurotherapy in West Germany, as most of you know, is the foremost used modality to treat pain. The overall success rate, if you just use neurotherapy, and just to introduce myself a little bit more, I have a pain clinic in Marseille. So 80% of what I'm doing is just treating chronic pain, and maybe 20% I treat chronic other diseases like MS or chronic fatigue, some of the other things that you all see in your practices. But I will be often referring today to chronic pain as what for me has become the model for all chronic pain. I essentially don't believe there is a difference between having chronic pain and having chronic fatigue. It's such a different manifestation of the same underlying processes in the body. And so interrupt me if I'm saying the word pain too much, or you have questions that also applies to other things. It's just my way of thinking. When I first came over here to the US and started using neurotherapy, I was first very disappointed. I found that in the beginning I didn't get the same results that I used to get when I was in Germany. And I was wondering, well, maybe it's just a belief system that the Germans have created, and you have to believe it to make it work. And I noticed later on there is some differences in the way people respond if they're brought up in a different belief system. And it's very important to spend a little time with each patient before you actually start healing them, to help to create a internal framework for them where they can place what neurotherapy is. Otherwise, if you start, the first treatment like injecting somebody's tonsils or thyroid, since I don't have any place within the subconscious, it will create a lot of resistance to making it work. And so I will present you with my first lecture this morning the conceptual framework where I put the neurotherapy, and every time I have a new patient, I give them a brief of what I will be lecturing to you today to create the framework for the patient where you can place the idea of neurotherapy inside themselves and therefore bypass their resistance, which will make it a lot easier for you if you start treating people. If you introduce the technique properly, place it in the subconscious mind in a place where it belongs, you will be sailing through the procedures much more smoothly, and you will receive much more dramatic and fast results. My clinic is called Center for Human Development and Human Therapy, so we have a large focus on psychological aspects of illness, and I believe that was a very helpful change from changing it from Santa Fe Pain Center to Center for Human Development. That also, just the change of the title of my clinic has changed the initial success rate that I'm seeing in people, them being much more ready to respond to what I'm doing. Why don't you show the first slide? I'm going to take you a little bit through a mental process here for the first 30 minutes. Here's in the life middle. This is a study that I did on 20 patients in association with a chiropractor friend of mine by using a pain index. Pain index, this is also called an analog pain score. The patient is basically asked to rate their pain level on a scale from 0 to 10, 10 being the most and 0 being the least. And the patient in chronic pain usually presents, when they first come to the doctor's office, with a rating of anywhere between 8 and 10 on an analog pain score. And these are 20 patients that we followed over chiropractic treatment over a 4-month period. And you see, initially, when they had the initial treatment, they responded fairly fast, and then less and less improvement after 3 or 4 months. We analyzed this on a computer, and it's an exponential curve, which I believe is very interesting to the ones that understand a little bit of math. That the response to a single treatment modality is vaguely follows exponential curve. That means fast initial improvement, no improvement after a while. Now, go to the next slide. Now, for me, the question came up there, well, how the hell ever patients do get well? How do they ever get from a pain rating of 8 or 9 to getting better? And I went back in my charts and looked at actually some patients and followed every visit they have, which is possibly 1 a week. They fill out a pain drawing, which then gets translated into the pain index, which is the scale on the left side. How the hell do the patients ever get well? What happens that they don't follow that exponential curve? And this is a patient, a Hispanic patient, that I actually drew out to see what happened on the way to him getting well. And when you follow it, initially he was treated with physical therapy, which in his case was electrical stimulation and ultrasound and exercise, those 3 things. And we see he followed the typical exponential fairly flat curve. Then shortly later he had massage that was added in the treatment. And if you understand anything of physics or math, you see that the massage, which was started about 2 weeks into the treatment, had no effect whatsoever on the progress of that patient. Another 2 weeks later, the TENS unit was given to him, which again had no impact whatsoever on his progress. We will interpret that a little later, what that means. Then he was started on a number of, I call it your vitamin supplements. In his case, it was actually more than just vitamins, but there were nutritional supplements that were started, and we see that he again starts following as if a fresh exponential curve is starting here. Shortly afterwards, his lawyer sent him to an attorney, sent him to an orthopedic surgeon who started him on non-steroidals also. And we see here again the non-steroidals had no effect whatsoever on the progress of the curve. And then again, a few weeks later, I started him on treatment with injections, which again gave him a new dip in the curve that he followed. Shortly afterwards, his orthopedic surgeon started him on traction. Then he started seeing a chiropractor on the advice of his attorney, with no obvious change in his progress. And then as the last step, I sent him to a friend of mine, a psychotherapist. Could you focus it a little? Okay. And we see again that the psychotherapy again made a difference. So what we see here in this curve is this: we see treatments that made a difference and treatments that made no difference. And this looks very simple and primitive, but it has a tremendous impact if you think this all the way through. What this means, if you go back to the beginning, that the physical therapy modalities that we used started him on an improvement, that the massage and the TENS unit didn't create any further change in here, means that whatever the physical therapy is doing is, or whatever the massage and the TENS unit is doing, is already done by the physical therapy. That means that the TENS unit is doing the exact same thing that something in the electrotherapy, ultrasound, or exercise is already done. That means that these units all work on the same component of pain, that there must be a component of pain. If that's addressed by one modality, then adding in 3 or 4 other modalities of the same kind does not give you any more benefit. And this really is my discovery. It sounds very simple, but has a tremendous impact in streamlining and determining what you're going to be doing with the patient. The same thing with the vitamin supplements. Vitamin supplements obviously do something that a TENS unit hasn't been doing, or the electrotherapy has not been doing. That means this is a different component of pain that's addressed with the modification of the biochemistry in the body. And interestingly here, the non-steroidals didn't give any benefits. Now non-steroidals, we also know, modify in some way the biochemical events in the body, just the same way that vitamins and nutritional supplements can do. And in this case, had no further contribution to improving the patients. That means whatever the non-steroidals do was already been done either by the vitamin supplements or by the physical therapy. That means we can do the same thing with physical therapy and vitamin supplements that non-steroidal and inflammatories can do. It sounds like a very simple thing, but it's a great discovery. Just by simple observation of the progress of the patient, and of course I followed other patients. We evaluated about 60 patients and found the same truth in every one of them. Are you following me so far? You doing okay? Okay, now if you take this further, the next treatment here are proliferant injections, which are injections that change the structural strength of ligaments. Again, chiropractic manipulation and traction fail to improve on any of the previous modalities. That means whatever they do has been contained already in the previous modalities. And the only other treatment that we found that made a difference was psychotherapy, meaning that psychotherapy is also treating some component of pain that is not addressed by physical therapy, by modifying the biochemistry, or by working on the structural component of pain. So looking at this, and after I reviewed many other patients, I came to know that this is the truth for every single chronic pain patient that you observe, that there is 4 distinct components that their chronic pain has. Number 1, let's start at the end here, being the psychological component, which can be reduced to biochemical or neurochemical changes in the brain, which is a distinct category of chronic pain that occurs usually some months into the event of the onset of the chronic pain. Let me first define here what chronic pain is. Chronic pain is defined by pain that lasts 4 weeks longer than the expected time of healing would be from a particular injury. For example, an ankle injury, the ligamentous injury in the ankle, should heal within 6 weeks. If after 10 weeks the patient is still hurting, he is a chronic pain patient. The difference between acute pain and chronic pain is that acute pain is a symptom of an illness or injury, an alarm sign in the body. For example, if you have pain in the right upper quadrant, it may be the alarm sign that you have an inflamed gallbladder. However, chronic pain constitutes the illness itself. That means chronic pain is that pain that persists past the structural injury is here. That means I can have right upper quadrant pain. You go in, you don't find an inflamed gallbladder, you don't find inflamed appendix, you don't find something wrong with the colon, you don't find anything wrong with the liver. This is chronic pain. The pain is felt in the area, but there is no more structural, organic basis for the pain. The pain has become an illness unto itself. Now in chronic pain, there's always neurochemical changes in the brain, which is one component of the chronic pain. The second component, if you just go from left to right here in the chart, the second component of pain, of course, is the structural injury. Somebody lifting and straining their back. This is one component of chronic pain that most of the time is there, but doesn't need to be there. Like we know the fibromyalgia syndrome does not have any structural injury to start with, but the pain syndrome that starts insidiously without any precipitating cause. And the third component of pain, and that's what you've heard so much about the last few days, is what I call the biochemistry. then the fourth component of pain, which is what we're here for, is what I call the electromagnetic component of pain. Let me explain to you a little bit what I mean with that. Let's go back to physics a little bit. I try to keep my lecturing today as simple and clear as we can, moving away from any concepts that are somewhat tinted by ideology or belief system. First of all, let's go back to physics. What's an electromagnetic field? We know that when you have a wire where there's some electricity running through, there's a byproduct. The flowing electrons create a magnetic field around the wire with a force going 90 degrees away from it, magnetic force. So whenever there's a flow of electricity, there's a magnetic field set up. And vice versa, whenever there's a magnetic field that moves, it induces the flow of electricity in its core. Now, applying this to the body of any alive substance or even a stone, the summation of the electrical events in the body, mostly located in the nervous system and autonomic nervous system. When I have a nerve impulse flowing, let's say I take a step, the sensory input from the foot is traveling up to the brain. That can be translated, and the ultimate physical event in that is the flow of electrons, just like in a wire from the foot to the brain. This electrical event creates automatically, as a law of physics, a moving magnetic field around the conduction of this impulse. If all the electrical events simultaneously in the body could be recorded, the summation of all the electrical events from moment to moment in the body set up a magnetic field in the body and around the body. Now, I'm not talking anything esoteric here, it's just simple physics. Whenever there is electrical events, there is magnetic events. This translates into a magnetic field that the body has, which is constantly changing depending on the events in the nerves. But this is constituting what in religion and so forth has been called the aura, or whatever terms you've heard. This is a very simple physical phenomenon that the body has a magnetic field and electrical events inside. Now, we know we can deduce from or infer from such treatments as magnetic field therapy that by modulating the magnetic field of the body, you can change the conductivity of the nerves, you can influence pain, you can influence chronic illness by modulating the magnetic field that the body has, which is just really, like I said, simple physics. If you change the magnetic field, you change the flow of electricity, which is translated in the body as a change in conductivity in nerves and a change in neurotransmitters in the synapses of the nerves. And let me go to the next slide. I just want to take it quickly now through the four components of pain, the treatment options that are available, so that we can place neural therapy today in the exact right location, both in your mind and where it belongs in the treatment. So the first component of pain, you have a copy of that, is the structural injury, and I listed just a few of the treatment options that are there. And remember, if you do one of the treatment options, you don't have to do any of the other ones. Don't duplicate what you're doing, because you're just wasting the patient's money and time. Exercise is a wonderful treatment option for structural injury. But for example, if you have a displaced sacroiliac joint causing pain, one of the most elegant ways of putting it back in its normal alignment is having the patient exercise. The movement will eventually, either by accident or by plan and design, move the joint back. And Alec Thompson here is one of the people that taught me a wonderful exercise for the sacroiliac joints, which has replaced much of the injections that I used to do. Manipulation, of course, is a treatment on that level. Traction, wonderful treatment. Surgery, a treatment that should not be forgotten. And highlighted here, the joint and ligament stimulation of the fibroblasts, which are the cells that secrete collagen and elastin. That means you stimulate the body's own cells to form new ligament. This way, and that's been proven in many studies, both physiologically and mechanically, you get a stronger, shorter, and more elastic ligament. You get a better and more efficient ligament by injecting these substances into a joint or a ligament. Next slide, please. This is just quickly how I do this procedure. It's not important here, but it is important for the people that treat low back pain and neck pain by modifying, I call it oh God, I forgot the term that I used to use, but I call it a modification of neural therapy by adding in a 10 cc syringe of local anesthetic, by drawing up the local anesthetic only to 7.5 cc and drawing up 50% dextrose, 2.5 cc. You get a wonderful proliferant. And by injecting the low back with this solution, you not only get the therapy effect of neural therapy, but you also get the added effect of strengthening the ligaments. In this way, you get a much more effective treatment. This is quickly how I do it. I take from the X-ray, I take my landmarks where the sacroiliac joints are. These are these red things here. The iliolumbar ligament and the lower 3 lumbar facet joints. This is transferred on the patient's back. Next page. And I get a little drawing like this, which are my injection points. This is the point overlying L5S1, ligament. They're exactly the same location when you do neural therapy as when you do the proliferant therapy. This is the interspinous ligament in the lower 2 levels. This is the L5S1 facet joint, L4-5 facet joint, and this is the sacroiliac joint. You need to get about half a cc of the solution that we just mentioned, which is 12.5% dextrose. Half a cc in each of these points. You move the needle down, move it around until you have contact with the structure that you would like to place 0.5 cc there. And 5 cc of the solution gets placed in the sacroiliac joints with little dots of medication put around all the joint. And I inject this joint from this needle position on here, which is proven to be the only needle position from which you can reach all the way into the joint, which is underneath the ilium. And the iliolumbar ligament runs roughly from the transverse process of L5, this is about here, to the ilium in this distribution. So the needle insertion is here, and you contact the ilium from the side here and place small amounts of medication, about 1 to 2 cc on each of the ilia at the insertion of the iliolumbar ligament. This is just, we're not here to learn proliferant therapy, but since this technique was exactly the same that you use for the treatment of low back pain and neural therapy, that would be good to mention that here to you. And if you have any volunteers later, anyone trying low back pain, we can demonstrate the technique. Other than that, when you use proliferant, this should be learned hands-on at a separate seminar, just because proliferant can have some potential side effects when injected in the wrong place, but you don't have when you just pour the neural therapy. Next slide, please. This is just the needle that I'm using is a 3.5-inch needle, fairly long needle. It's needed to reach all the depth of the sacroiliac joint, which is not often appreciated by many of the people that do this procedure. Next slide. This steroids, gold, and malaria drugs and so forth. Intravenous colchicine, which is a wonderful treatment for chronic discs and acute discs, which are physicians here that treat pain. Please use this modality. Intravenous colchicine is 1 milligram twice a week for about 6 weeks, and almost every acute disc you can heal that way. Chronic discs, you use it as an additional modality. Colchicine is an extract from a plant, and I have never seen any serious side effects from it. I've never seen any complications from it. And since we're also practicing IABDM modality, I've never seen any repression of the immune system or any negative other sorts of events from this particular drug. And I think it has to do with that it is a straight plant extract, grown in nature, and doesn't have any of the severe immune repressing side effects that steroids have. This is, I'm referring you to the medical colchicine that comes only in one strength. It's 1 milligram per annum. However, in Germany, I've observed that people are using homeopathic colchicine, which is also available, of course, with colchicum, and they need to muscle test for the potency or use the ERD equipment to check for the potency. I've tried it myself. It's somewhat less effective, but it seems to be that if you use the homeopathic, you need somewhat more treatment, but you get to the same end result as you did with the medical using colchicine. So there's those two options. Anyway, next one is cryotherapy. Cryotherapy is the application of cold. You use an instrument that is placed, for example, if you have an inflamed facet joint in the low back, it's an electronic probe that gets placed onto the facet joint. When you stimulate electronically, it needs to reproduce the patient's typical pain. If it does, then we know we have the right location. Then we switch the probe, and then with liquid nitrogen, the joint is frozen for about 6 minutes. It is dramatic and long-lasting pain relief. It lasts about a year. Less than that, if you don't do those things. But you can get somewhere with 1 treatment, 1 year's pain relief, which is a very, very valuable treatment in many cases. Next one is the arthritis vaccine. There's several different kinds. We use the one that Gerald turned me on to. It's from Palm Springs, from an arthritis clinic there. Contains different types of vaccination and leads to specific immune stimulation, which can be very effective in the treatment of rheumatoid arthritis and other types of arthritis. Then, of course, in this category fits our homeopathy and herbal therapy, vitamin and mineral supplementation. I'm not going to go into that because you've heard so much about it, but this is where I place in my mind where homeopathy belongs. And the most effective treatment when you're dealing with chronic pain in that category, in my opinion, is the treatment with venom injections. Next slide. This is quickly a breakdown, an electrophoretic breakdown, which we had done on the venom. I've been involved in some research on that in the last few years. The most important components are peptides that are contained in venom. One is called melatonin. Melatonin has a very strong effect on the chemistry in the brain through ACTH stimulation, and therefore leads to elevated plasma cortisol levels, which are specifically elevated in the area where you inject venom. And the next important peptide is apamin. Apamin is a very strong peripheral pain-relieving substance. And the last one is the mast cell degranulating protein, which has a strong anti-inflammatory action, about 100 times as potent as hydrocortisone. And next slide, please. there's a certain protocol that we follow that you would have to have before you use this modality. You start with one bee sting, wait 20 minutes, and then get 3 more the first session. And then you treat twice a week, and you go up 2 bee stings, and really have arrived at about 20 stings per week. And following this protocol, I have not seen one allergic reaction. There's one precaution. Bee venom requires a strong response of the pituitary and of the adrenal glands. If you're vitamin deficient, this is riboflavin, vitamin C, B6, and B1. Those need to so on those we give people before we start the drug. Even as a precaution, I have not seen any one single allergic reaction. And I've treated people that had been in the emergency room unconscious after they've been stung by bees in the wild. So what I learned from that is that a bee sting out in the wild with the element of surprise and is different from the bee sting that you give in a controlled environment provides. But the element of the fear or shock has to be there to provide even the allergic reaction. I think it's a very important impact.
As a counterpoint in a way, although I don't really dispute anything that you said that you told me about the bee venom several years ago, I called up Charles, I said Brad, and got him the thing, and started doing it on some of my patients. Well, I abandoned it because I got severe allergic reactions, but if you have a chronic type of swelling, pain, and itch, that it just made me miserable. And so I've abandoned. Now that doesn't mean that I don't do irritant therapy to stimulate the immune system when I do irritant therapy for the immune system. And also I've been, as you know, Dr. Rask, known for a number of years, and I've done the colchicine treatment. And frankly, I haven't done work on a single patient, and I even did work on a gout patient. Now, I am not saying that you're up here lying to us and that there are no allergy reactions, etc. I'm just saying that in your experience, you have no allergy reactions. Michael Rask's experience, he's done thousands of people and has done herniated discs. But what I'm suggesting is that there's a marked geographical differences, what I think.
Yeah, I agree with that. I live in Santa Fe, New Mexico, where we do have probably one of the cleanest environments here in the U.S. And what I'm referring to with allergic reactions with bee venom, I meant acute allergic reactions. I've seen delayed phenomena where people have like an ache in the injected area for up to, maybe the longest I've seen is 32 weeks at a time. And I've seen people get in a low energy kind of situation. But it was only in the beginning, since I've done the vitamin supplementation, I've been seen it once. And I think it's a good point here. Your pituitary and your adrenals have to be in a state where they can respond to the stimulation. And if you see that chronic, the people go down, so that you measurable for a couple of days, you know that you didn't fill out their stores or B1, B6, riboflavin, and cleanic acid, vitamin C, those are things that need to be there. And I'm not making this up, but I have not seen any of these reactions since. And with the fluoxetine, I had a very dramatic response to it, especially in the older population, older patient population, and acute hits with young people. Over and over, the award, and so on. I can explain that, and I know I've heard the same argument from Bob Klein, with the potency that he couldn't make it work on his patients, and I don't have any explanation for that. Why it should work in one area or one patient population or different. But anyway, let's move on because we want to. Yeah.
Does this have any application for osteogenesis working in space?
You mean the bee venom? Yes. The TMJ, I'm just kind of searching. TMJ is probably the only indication. TMJ and the upper facet of the neck is one main article. Often one bee sting at a TM will give you dramatic long-lasting generally appreciate it. Unfortunately, many dentists, that in my area actually start manipulating around with and with splinting and all kinds of other things and overlooked. So the patient has an elevated sedimentation rate and all the implications that come with it. And those patients usually don't do well at all with any splinting or other procedures, but they do very, very well with just one lesion or over use of the joint. Even needs to be injected with the convenience is another thing. It's like too deep, there's no effect, the benefit or whatever. And then the incidence of people getting sick afterwards is higher. So it needs to be in the most superficial layer of the skin.
Dietrich, have you compared the bee venom to, let's say, a plum blossom with the bond shot oil on the outside?
When I was in Germany, I've tried all the irritants that were on the market then. And there's a list that I couldn't even name, and I've just never seen the dramatic, long-lasting results that I've seen from the bee venom.
Dietrich, on it too, is there any problems in terms of getting the exponential healing fixing these? In other words, if you use the arthritis vaccine plus the bee venom, still trying to get
You can always mix it. You may get a steeper curve that way. There's always a possibility, but the patients that I've looked at, charted out at pain drawings that I've never seen, or part of the patients that hardly ever saw. If you really do one modality right, that you need any of the other ones. However, especially in the category 2 in the biochemistry, it's so difficult to be right on, especially with homeopathy. You always only guessing, and then it's good to supplement with other things. However, one thing I have to warn with the bee venom cancels out the effectiveness of homeopathy. If somebody is treated with bee venom, the homeopathy doesn't do shit. Doesn't do anything. It's very interesting to me as a phenomenon. Why, what it means, and it's will be very interesting for some future research to find out why that is. So you have to make a decision when you use bee. You can use multiple. You have to use the vitamins that I just stated, and it's best to load people up before you start on the treatment. And then that means the nice winter sailing through very smoothly. This is a lady here, just as a demonstration with a severe osteoarthritic knee. She was actually married to a neurosurgeon and is one of the healing practitioners in Santa Fe. She was working on a cane, couldn't stretch out the knee beyond this angle. And she had 3 weeks worth of bee venom therapy next month. And here she's home straight to the dramatic effects that I have just not seen from any other treatment, especially in the knee joint. Because in osteoarthritis you always think in terms of bony changes, and that's permanent. And I've been just as much surprised, as you have seen these kinds of results on people. She had bee venom therapy. I taught her the procedure in the first treatment. She was doing it herself every day for 3 weeks, which I commonly do. Commonly people that especially live outside my town, I teach them how to do the procedure and how to do it themselves. And they have a little kit there, to actually stick with adrenaline. Get some Benadryl at home just in case anything ever would happen, which never do. They would have it there. Next slide. This is just a study I did with my own patients on the improvements that we had with the bee venom. And there's a list of things that we treated from now to rheumatoid arthritis, fibromyalgia syndrome, several ligament injuries, disc injuries, wonderful for bunions. If you ever had anyone with a bunion, that's the only treatment that works quick and effectively. You don't have to think. Put a bee sting in there about once a week, 3 or 4 times, and the bunion becomes completely painless and stays painless for many, many weeks. That would be a good starting point for many of you, because I think it's only the equivalent of 1 sting per treatment, and it's extremely effective. We had other things, including one case of MS, who did really, really well. Okay, next slide. Okay, the electromagnetic disturbances of the body that we talked about already. Here's some of the treatment options: TENS unit, dorsal column stimulation for the physicians, then acupuncture, magnetic field therapy. I was just on this large conference in Europe, over 2,000 people attending on physical rehabilitation medicine. There was a whole day dedicated only to magnetic field therapy. It's in Europe and the rest of the world has become the number one physical therapy modality. That virtually has no limitations. You can treat anything from a stroke to a paralysis to back pain to headaches by putting a patient in a magnetic coil. It looks sort of like a round drum where the patient lies in. Very, very effective electro nerve block. Then surgery, I want to point out here two things. One is the removal of a mortis neuroma. There's something that came across in this last year very frequently since it was hard to look for it. A mortis neuroma is a sprouting nerve, usually on the sole of the foot. By wrongly or by standing on your feet in the wrong way, which according to a late estimate, about 99% of the population fall in this category. When you're walking, when you're standing, you put stresses on your foot that are not in a biomechanical right way. Your nerves on the sole of the foot will start sprouting, sending out little sprouts from chronic irritation. And this then leads to a condition called abnormal signaling. That means whenever you take a step or stand on that nerve, that abnormal pathological electric inputs that send out the nervous system, the sensory system, leading then to what's called now a mass effect in the spinal cord. That means the spinal cord gets overloaded with electrical impulses, and the screening mechanisms in the spinal cord stop functioning. According to the gate control theory, which is really not a theory anymore, we know that there is a mechanism in the spinal cord which blocks pain impulses traveling up the spinal cord. Otherwise, we'd be hurting, even healthy people would be hurting all the time, but we do have the nociceptors, the pain receptors, at all times active in the body. And it's just a matter of the spinal cord screening out of how much impulse it gets through. And if the receptors get overstimulated, then the impulses go through and you feel pain in the brain. That's where we always feel the pain. If you have a neuroma in the foot, we have an overload of the nervous system that leads to the mass effect of the spinal cord, to the failing of the screening mechanisms, and to pain sensations in the brain, which can be very indiscriminate. We treated many cases of fibromyalgia syndrome simply by removing the mortis neuroma on the foot, and it completely got pain-free. Lots of migraine patients, intractable low back pain, even cases of transparent seropositive rheumatoid arthritis, which were completely pain-free and had complete remission after removing of the neuroma. We have one patient here who was one lady, sorry, it's really nice. I don't hear now. I hope she can hear this after. And I'm going to demonstrate to you how to examine it, how to find it, how to treat it. But it's, it belongs to neurotherapy, even though it's been discovered by me living here in the US, not by the German neurotherapists, but it's a very, very important addition to neurotherapy to look for that. It makes a dramatic change in my practice. The other surgical condition that I would like to list here is the tooth extraction as the wonderful method of relieving a electromagnetic disturbance of the body. And I'm sure you didn't talk about teeth.
Yes.
Yeah, and we will talk about some later today.
Question. Yeah, concerning the metallic dental work that's in the mouth, we know that it measures electrical energy, but that energy is in the movement. You know, the mouth is opening and closing, and talking and eating and moving around. Now, that's creating a lot of the magnetic field, okay, which is aberrant because it's every which way, and there's a multitude of combinations and combinations that are possible. it's almost impossible to track and measure it. It's a great disturbance.
I believe, Franz Hopper, one of our teachers here, he quite openly disagrees with us on the importance of the amalgam removal in the teeth. And the reason for that is because it's so difficult to test for it. Like Ed just said, there's a disturbance field that only shows up with movement. When you move, you have an electric current moving, which sets up a magnetic field. However, if you hold your mouth still, which is a position which most testing procedures are done, you're often not finding any disturbance. So I think so that explains some of the different points of view on the amalgam story on different metals in the teeth. But there's something, and I do muscle testing. If you want to fully test for it in movement, if you test teeth often static, patient holding them out still, you don't find anything. You let them do this, and you test them, they go weak, they're harm in you. Does that answer your
I just thought amplify on it.
now, massage and body work, any body work, in my opinion, belongs in this category. Of course, some deep type of tissue work also work on some structural components of pain. But most body work, most massage works on the electromagnetics of the body, very similar to acupuncture. By the body workers, magnetic field interacting with the patient's magnetic field. And in all healing theories, that's very much appreciated. But it's not so much appreciated by us, as we walk through your life as a physician. You never think in terms of, well, when somebody gets massage treatment, you think of taking muscle out of the muscles and stuff. But really, at the bottom line, what it is, it changes the electromagnetic of the body. And now the most elegant treatment, of course, in this category, which really well, I just want to call the most elegant treatment in this field is neurotherapy. Now, there is still some place for the other procedures here. For example, like if neurotherapy works only temporarily, then you need to go to the surgical removal of the scar or tooth or an aroma. And the acupuncture really is not different from neurotherapy. Neurotherapists in Germany now increasingly use the injection of acupuncture points as part of the program. And really what neurotherapy is an extension of acupuncture. Everything that's true in acupuncture is true in neurotherapy. You can inject every acupuncture point with the same success by injecting it with a local anesthetic, except, and that's my way of looking at it, that the creators of the acupuncture system missed a few things. What they missed is the trigger points. We have a wonderful book, from Val, which everyone should have, which are often the same as acupuncture points, but there's some distinct trigger points that are different from any of the acupuncture locations, which are very, very important to know.
A point that you mentioned in passing is the fact that the metallic restoration and dentist treatment is a field of disturbance because it's a scar on the tooth and on the mesenchyme. I mean, it gets even worse than that because those metals are being electrically ionized and pushed into the tissues. And this is a point that physicians need to know when they see that, and the dentist doesn't see it. He says, oh, good margins, nice full color, everything, good shade, everything's great, see? And dentistry in itself is a disturbance to the body. It can't be anything else.
Also not to forget the TMJ. In my own experience, every time I've been at the dentist, I've got low back pain, and it took me many years to figure out that the reason I got low back pain is because my TMJ acted as an interference field for my low back. Anyway, we're going to go into the teeth work later today. Neurotherapy, from a medical point of view, there's three things that you need to have, and I think those are important to communicate to the patient. But to the patient, you talk about magnetic fields and those sorts of things was as a concept maybe too wide. There's three things that we know about neurotherapy. One is that we know that the injection of a local anesthetic onto a nerve or ganglion restores membrane potential. Very, very important point. The injection of a local anesthetic onto a nerve or ganglion restores membrane potential. Now that's in neurology now very much appreciated. Chronic pain means, for example, if somebody has chronic low back pain, that the ganglia, which are located in the epidural space or the sensory nerves, are chronically depolarized. That means the membrane potential is not 180 millivolts like it should be, but maybe 90 or 100 millivolts sunk down. That means that the ion pumps situated in the membrane cannot work. That means that the nerve cell itself is filling up with toxic material. The metabolic byproducts of the metabolic activity of the nerve. The byproducts cannot be shoved out of the cell and accumulate in the cell, leading to an immobilization of the cell. That means the cell basically is drowning in its own goo, in simple words. And by restoring the membrane potential with the local anesthetic, the ion pumps immediately start working again. Their function depends on the correct voltage of the membrane. If it's charged to 180 millivolts, immediately your pumps, if they've been not working for 20 years, they start working again. I had the fortune to study under Professor Fleckenstein in Germany, who was the discoverer of the ion pumps in the membrane. And as a medical student, long before I heard anything about neurotherapy, I worked on the functioning and the working of the ion pumps. And there's one residue that I know that he won't hear anywhere else, but it's absolutely scientifically confirmed that he was, unfortunately he never made the Nobel Prize for it, but he was one of the two candidates, and then somebody else got the Nobel Prize for the ion pumps that actually stole the idea for him, but it's amazing. Otherwise you'd probably know his name. But by restoring the membrane potential, the ion pumps start working again all the time while the local anesthetic works, which is, we know, half an hour for cocaine, for lidocaine an hour to 2 hours. And that time is enough for the cell very often to throw out so much of the old garbage that now the normal membrane potential can be retained by this functioning of the ion pumps again. It means the cycle is broken, pumps work again, the wrong minerals are transported out, the right minerals are transported in the cell, and the cell wall is functioning again as a proper unit. That means there's normal membrane potential, and that means in terms of chronic pain, that now the pain impulses can no longer travel up the nervous system. It takes now much stronger pain impulses to travel up than it did before. This is number one of neurotherapy that you need to know, because that's the core scientific piece in there that you won't get anywhere. The other one is that we know for sure that the injection of novocaine stronger than lidocaine relieves lymphatic spasms. Really with the same principle behind it. In the lymphatic system, you have the cell wall, the wall of the lymphatic channels, which for example, we know from some research that has been done, in chronic tonsillitis, we know that the body is trying to isolate the tonsils and not have a constant flushing with toxic material and bacteria into the lymphatic system. The body creates a spasm at the outflow from the tonsils or from any lymphatic node. It creates a lymphatic spasm of the lymph vessel, which becomes after a while self-perpetuating. If there's spasm, that again means there's a depolarized membrane in the nerves that innervate the musculature of the lymphatic vessel. That means initially the spasm is there in order to seal the infection into the lymphatic tissue where it was. However, long after the infection is gone, the spasm can maintain, and we know now that it can maintain for many years. And by injecting a local anesthetic onto the proper lymphatic vessel, the spasm is relieved, and if there's no more infection going on in the tissue, the lymphatic drainage stays open. And we heard some of that yesterday,
essential fatty acids and vitamin E also, can't you?
Well, then we're jumping over, in the other field of the underlying immunological biochemical events that are always accompanying these things. However often it's unnecessary. There would be, if you keep relapsing, if you keep losing your potential, if your lymph spasm keeps returning, then you have to look at the other components. And I'm going to mention in a few minutes here how I'm guiding my treatment that way. Yes.
If you have a patient that needs a lot of injections, what solution do you accept?
Well, we talk about that later. Yeah, let's get back to that later. Anyway, I want to present to you these two. There were 3 points. The third one I've forgotten what it was. The third scientific point, I may come back to it later. But those two things, lymph spasm and membrane potential, those things, you need to swear to me that you remember those. And give that to your patients as a piece of information when you declare what you're going to be doing.
You stuck that the Chinese acupuncturist had missed a couple of points with the nerve nervous.
Yeah, oh yeah.
Putting trigger points is the one.
Okay, let me go back. Thanks for getting back to it. The other thing that acupuncturists miss is that there is, and I call it acupuncture point, in the tonsil, in the thyroid, deep in the pelvis, in the epidural space. I tell to my patients, these are just additional acupuncture points that the Chinese have missed because of the lack of equipment and lack of sterility. They could not easily do those things. They didn't have, it was unpleasant to stick a needle in the tonsils, which you could do. Some people in Germany have done that. Some acupuncturists that didn't have the license to inject. They have the patient sit there with a little split in their mouth, and stick needles in the tonsil and leave them there for 20 minutes. And claim similar success rates that we have with the injections. So that's why I say that the acupuncturists have missed certain trigger points, and they have missed some of the neurotherapy points. And now the latest in China is that, of course, they've learned this from the Germans about the scar injections. The Chinese have never appreciated in their own system the importance of scars. And after the neurotherapists discovered that the injection of scars is so almost important to open up the circulation of the energy in the meridians and to treat pain and to treat certain illnesses. And it got carried to China, over the last 20 years, and now they have a whole branch of acupuncture departments that just deals with scars. Like, they're fiddling the needles along the scars and across the scars. And
To amplify and strengthen what you just said, last year we went to the East-West Congress, the first one in Hawaii. They had 10 physicians, PhDs from mainland China, and about 120 from Taiwan, and they were absolutely amazed that the teeth were stressors. I mean, they just ignored it. They didn't exist.
Yeah, and that's some credit I think we need to give to ourselves as Westerners, that the discovery of the importance of scars, that it comes from directly stems back to the brothers Honecker, who invented, if you want, neurotherapy. And the Chinese are now promoting it as their discovery, like they always do once they get hold of it. There's this whole new thing in acupuncture that they're teaching, and people from Germany are actually flying over there to learn how to treat scars. And the Chinese probably I'm good friends with the director of the Chinese acupuncture school at Santa Fe, and they're all admitting that's where it comes from. They read the neurotherapy book from Doshin, and since then they know about scars, and they try to figure out ways how to simulate the same effect with acupuncture.
One thing I brought out yesterday, I think it deserves to be emphasized, that both the Germans and the Chinese, the acupuncturists, because of those chiropractic or osteopathic background, do not realize that treatments have, particularly the neural therapy, being dependent from acupuncture because it works on a structural layer, on a structural level, as well
correlate in the tissue, that makes it work. And they've actually, after long research, found that very frequently scar tissue contains neuromas, that means sprouting nerve endings, that again, similar to the neuroma in the foot, leads to abnormal signaling, that means there's constant uncontrolled input into the nervous system from those sprouts. They don't have normal nerve endings that need proper stimulation, but without any stimulation, these nerve endings then give pulses into the sensory nervous system, are really leading to an overload to a mass effect of the spinal cord. We know, in fact, now that there's virtually any scar, there's places where there's neuromas, and by injecting the neuroma with a local anesthetic, we repolarize the membranes and can very frequently lead to a stabilization of the membrane over a long period of time.
Do these scars summate?
Yeah, there's a summation. Well, there's a whole other part of pain theories. There's a summation theory that we know if, let's say, we have a neuroma in the foot, and we have an old fracture with a scar neuroma, and we have, let's say, an old knee injury with some inflammatory changes, that all these impulses, sensory impulses in the nervous system, summate, and there's a certain threshold from which one leads to the mass effect, that means uncontrolled information passing up in the spinal cord, and that means your migraine can be treated by just reducing the mass input of summation. That means the migraine can be treated by working, adjusting the neck or doing some injection homeopathically, but you can also treat it by removing the neuroma in the foot, injecting the neuroma in the appendix scar, treating the long-standing knee pain, and if you reduce enough of the equation, suddenly boom, and your migraine is gone, just because of the summation of events that travel up from the spinal cord. And this is a very, very new concept of chronic pain that you need to get, that you don't, and that's often, and it's in my opinion, why neurotherapy works. Because with neurotherapy, you reduce this sensory input from many different places, and if you reach a critical point where you go under the pain threshold, your symptoms that you've been treating goes away. And I disagree, in that way, in many ways, from the neurotherapy teaching.
This is the same concept that we like to, as biological dentists, like to tell people that we're reducing the stress load in the mouth, and we have the potential to reduce it to the point where all the chronic symptoms will go away. And not all the time, but a good chance.
And you see, we come to the conclusion of this talk in a couple of minutes, and this is basically what I got this award for on this last conference, is this observation that in order to treat a symptom of illness, you can start anywhere in the body reducing pathological input of all sorts, and you decrease constantly the summation effect, and it's very suddenly that you pass underneath the threshold and your symptom is gone, even though you've never addressed the particular symptom that you're treating. That's a concept I'd like you to all go home with, and that's the reason why there's chiropractors and nutritionists and massage therapists, and they all seem to be treating the same illnesses, and they all seem to be getting results. But it doesn't matter which angle you have on attacking the body. If you start reducing pathology, you reduce the equation that leads to the mass effect in the spine, and you reduce until suddenly you pass the threshold and you're in a pain-free area. But I'm getting to that in a minute. Let's go on. This is just, it was a demonstration for the seminar. This is a guy, 15 years ago, he had a motorcycle accident and had a stiff shoulder, and he had about 90 degrees of abduction of the shoulder. You see the scar here is a splenectomy scar. It took the spleen out after the motorcycle accident, and ever since then he had a stiff shoulder. He was treated with surgery, he had some scars on the back, steroid injection, everything, you name it, and he's left-handed. He could move his arm back. Next page. This is just a better view view of the scar. Next slide. This is the injection of the scar, which hopefully we get to do today, because I would like to teach you also to correctly inject the scar, which makes all the world of a difference if you do a scar. I've for many years believed when I started out with dual therapy, well, sometimes it works and sometimes it doesn't. However, much of that was because I didn't know how to properly inject the scar and was never taught. I went to many dual therapy conferences and was never shown in detail how to really do it. So this is a scar injection. I added a little venom in with the scar injection, which gives me much more mileage with dual therapy. With dual therapy, often you inject the scar, you get a day of pain relief, then you go back, you do it again, you get 3 days, you go back again, you get 2 weeks, you go back again, you get 2 months, you go back again, and it's forever. If you add the venom in it, usually you can do it once. That's the difference it makes. Next slide. This is 2 minutes after the injection. It's not full range yet, but it's, he gained another at least 30 degrees within 2-3 minutes after the injection, and it took then another couple of hours to get full range of motion. The one point I want to make right away here: when you treat pain or dysfunction of the musculoskeletal system, it is so important, and it's the most important technique in neurotherapy that I want you to go home with. When, for example, let's give it another example. If you treat a neck pain, and you, let's say, try to inject tonsils for the neck pain, the old concept of neurotherapy doesn't work anymore, that you can hope you're going to get a Honecker phenomenon and within a minute after the injection, all your neck pain is gone and the patient's going to be pain-free. What you see much, much more frequently is that you had a neck that was painful and had, let's say, to the right side, 20 degrees of rotation and all the other movements for full range of motion. You then go inject your tonsils, and then you go back within 2 minutes and check the range of motion to the right side. Is it still 20 degrees? And what you most commonly will see is then, wow, now I've got 30 degrees. You get a 10-degree increase, which proves you've done the right thing. The tonsils were the interference field, but one injection didn't give you the whole treatment. Now, most neurotherapists in this country that I've seen miss that because they don't do a careful exam before and after the shot. If you do this, then you know, okay, my tonsil injection getting me 10 degrees, you send the patient home, you have them come back in 2 days. In 2 days, you do the next injection. You again check your range of motion. Most likely, it still will be improved to 30 degrees. Now you do your next injection and check again, and you get your next improvement. You don't get your next improvement, then you go on to the next tissue. You do the sinuses. Again, with a very careful evaluation before and after the shot, you know if this tissue did something or not. And if it did something, you go back to the same tissue 2 days later. And this way, in a very sequential, methodological way, you get your patient well consistently without having to do guesswork. Now, this applies only to the musculoskeletal system, which is the easiest to treat because of this observation. And in neurotherapy, this is called a chain effect. That means that in this particular example, the tonsils were part of a chain of foci, chain of interference field, where the neck wasn't caused by just one interference field, but let's say 2 or 3. It's rare that it's more than 3, but it's very frequent in my observation. It's more than 1. And the only way you find out is you follow this approach. Same with the low back. If you go have a severe low back, you do a straight leg raising test. You take an exact measurement. I have an instrument here that I'm going to show you later. You take an exact measurement of the degrees when your pain comes on. 40 degrees the first time. You do, let's say you're in a woman, a frontal ganglion block. You go back within 2 minutes and check again, has it gone up from 40 or is it still 40? If it's still 40, you never have to go back to that injection. You do the next one, let's say you do the appendix scar, you check again, now we've got 60 degrees. Then you stop, with every improvement you stop, you tell the patient you come back in 2 days. After 2 days, you go back to the appendix scar. First, again, you check. it's still there. Do your penny scar. Now we got 75. You stop there. You don't go again. 2 days later, you haven't come back. 75 degrees are still there, or they're not there. But if they're still there, you go back to the appendix scar, do it again, 75 degrees to 90 degrees. Now you're there, patient is pain-free. Only if you follow this methodological approach, really be knowing what to do when the patient comes in back the next time without having to do the endless guesswork that the German neurotherapists do, that I've seen them doing, or to do one thing and they miss a little improvement that was there, so they go to something else and do something else, and the patient gets injected hundreds of times and all kinds of tissues, and eventually, of course, he also gets better because of the summation effect that we talked about. That you know, just kind of randomly sort of slash your way through the body until you get there. But with this way, if you follow a just simple orthopedic evaluation by using range of motion and the pain analog score, asking the patient, you know, before the injection, how much is your pain on a rate on a scale from 0 to 10? How much is it now? And
I have to add for the dentist that we do the same thing in the mouth. Of course, the meridians are in the mouth, and the energy circuits are in the mouth. So you just systematically go around it, and then you have the patient reevaluate or move their arm if they've got a frozen shoulder or whatever, or let's say it's back pain, whatever it is, and then you get exactly the same thing that you do.
Yeah. The point that I'm making here is like, for example, if you treat a shoulder pain, and this is just a simple example, you don't only measure the range of motion and lateral adduction, but you take forward adduction, you take extension, you take the resisted motion, that hopefully we're going to have time to go through the shoulder exam today. You take as many parameters as you can get on the particular joint that you're treating and assess before exactly as much as you can the angle and the degree of pain that you have. Before you do your intervention, then you do your intervention, and you go back and check all these. And if there's one of them clearly improved without having to do guesswork, by an angle that you can measure, or by a pain rating that's clearly come down, then you stop your therapy there. You don't go on that day, but you will go back to the same tissue the next time to see if it further gives you improvement. That's most consistently what I found, is what I've just described. That this way you find very clearly the scar or the area where to start, and you stay with that tissue until it no further gives you any improvement before you move on to another tissue. And very often with just doing 1 or 2 interventions, you get the patient completely pain-free, rather than having to have 20 things that you do with a patient, which is German neurotherapists do, 20, 30 things in one session. You do the whole body from top to toe, and of course you observe an improvement, which often isn't lasting. And then every time you see the patient, you have to go through the same 20 things again, because you don't know which one it was that did the trick. And it gets very confusing and very invasive that way. I've been visiting in a large clinic in December, treating all the Olympic athletes, and it was very horrifying to me to see the way they approach those patients like a piece of meat, you know, where you really sort of walk your needle all over the patient, up and down, and nobody ever checks back. The next time when the patient comes in, they ask him, how did you do? There's no exam before, no exam after the procedure. The only thing is like to ask the patient next time, well, how did you do? Well, you know, I was better for a couple of hours and then I was back to the same. So let's do the same thing again. And this is the common approach there. And I think with us, being in America, we need to take a certain leadership role in sort of sorting through this crud and making it work for us here in a more elegant way. Let's go to the next slide. This is just some other neurotherapy. This is a guy with sciatica that was relieved from the injection of the laminectomy scar. Next page. And yeah, this was an interesting lady she was scheduled for hip surgery the next day, and she came to me sort of asking if I had some other idea. We treated her cesarean section scar, was completely relieved of hip pain. It was over a year ago. Next slide. Component most fascinated with presently is the neurochemical change within the brain, which are initially triggered by the pain and later act as an independent, self-perpetuating phenomenon. Now, I could talk for hours on this subject. One very important thing that happens often is, and I've learned that through injection treatment, by doing the prolotherapy in the low back, if you treat somebody with deep injections that are painful, this patient will be hurting for a couple of days afterwards. If you treat somebody with the same injections and you give him some Demerol and Versed at the time of the injections, his pain will be gone within 2 hours after the injections, and you won't have any pain for the next 2 days. As a general rule, that means when I hurt somebody while I inject him, the imprint of that hurt goes in the brain and stays there for a couple of days, contributing to the pain sensation that he has. Whereas when we disconnect him at the time of the pain from the pain, we've done him more hurt afterwards because the brain doesn't have the information to hold the pain there. Now, often in the moment when somebody has a car accident, very much depending on the emotional circumstances of the accident, there's going to be an imprint of the accident and of the injury in the brain, which is independent of the actual injury. And this imprint in the brain needs to be treated separately from the pain. That means you can't do your structural work on your whiplash injury for years and not get a patient well unless you address at the same time the imprint and the memory that he has of the moment of the injury, the circumstances, his family situation around that time, the struggle he just had with his wife before he ran into the wall, and so on and so forth. The incredible important piece of information that pain is in the brain. I think we all agree on that. If you don't have a brain to feel it, you don't have pain. It's up here, and which we know very much from the phenomenon of phantom pain. And you don't even have to have an extremity there to hurt. That there's a neural matrix in the brain that has the information of the whole body, which can be separated of what actually is going on in the body. We know from the phenomenon of phantom pain that people that lost their genitals in an accident, they can have phantom orgasms, phantom erections. They can have people with phantom pain. They can have itching in their little finger. They can have cold hand, warm hand. That means that independent of actually the body part being there, there's a part in the brain that completely retains the memory and the picture and the sensations of this particular body part. And this is so important in treating chronic pain to know that your pain sensation can be entirely in the brain without any anatomical correlate being there in that part of the body where they're hurting. And this part of the pain can be treated only by addressing directly the brain. Now, here's some of the modalities that do that. One, of course, is medication with painkillers, tricyclics, other psychotropic drugs, Carotol, mayo inhibitor, so on and so forth. Psychotherapy and hypnotherapy, of course, are the most well-known characters in that category. Psychotherapy, in general, I found extremely ineffective for the treatment of chronic pain. And if any one of you has any experience with chronic pain, you will all agree with me. But just experiment with that over and over and over again, that I've just found that the common psychotherapeutic you know. Music therapy, that's one of the latest. Norman Shealy turned me on to that one. It's called the Baytar table. It's surrounded by a dome-like structure with loudspeakers being in certain strategic positions. And there's 3 types of music that are used. One is Mozart, Gregorian chants, and some of the New Age music that seem to be working best in order to relieve chronic pain or chronic depression. And those effects are very, very profound. And I won't go into this because nobody knows how it works, but it's a very important treatment that I think for the future that we'll be hearing about a lot. Beta costs now like $30,000, so it's not a cheap instrument. Then we have the cranial electric stimulation or transcranial tense unit, which is something I'm using since a few months and I'm very happy with. It's a tense unit with a special waveform where you have an electrode on each side of the temples, and the current flows through the temporal lobe. And I will show you later on in the slides, I hope you have been there, why that works. And the transcranial tense is a new modality which you will hear about a lot in the next coming years. I have a whole other study that we did on that. It does tremendous changes in the beta endorphin level, the serotonin level, acetylcholine, choline tremendous change in the neurochemicals in the brain. This treatment is given 1 hour every morning before 1 o'clock needs to be done because you get tremendous melatonin changes. You do it in the afternoon, you can't sleep at night. Now, the most dramatic technique in this category is the Downing technique, or also called neurosensory development technique. Next slide. This is the instrument. The patient sitting with the back to us. It's basically like a large slide projector. The little hole there is a lens which flashes light in the eyes of the patient. In this particular instrument, there is 13 different colors that can be given or selected wavelengths of light that get flickered into the eyes at certain frequencies. This instrument comes with a very sophisticated evaluation technique. Next slide. We do visual field testing as part of the workup for the different colors. The visual field is you move an instrument here from the side, for example, with a little white dot on it, and the patient says when they see the white, this is how you obtain a visual field, but you do it, there's a new discovery with this instrument, you do it with the different colors too. Next slide. Now, here's a patient that I've seen with a severe car accident 15 years ago, with injury to the pituitary, a branch of the tree went under the eye, all the way to the back of the skull, coming out the back of the skull, was surgically removed, and she had tremendous trouble, especially from the side of the pituitary gland, with weight gain, temperature changes, hormonal instability, dramatically ill patient. Very beautiful Hispanic woman. We see here on the first day when I saw her, we did a visual field testing. We see the visual field for white light, which is almost normal. And then you see very contracted visual fields, especially for the color green, which is that little ring in the middle. And red also very contracted, blue a little bit better. The little circle on the side is a blind spot. Here on the side, could you make it a little bit more sharp? You see the pain drawing that we're getting on each patient? No, just focus it a little bit more. Anyway, there's little dots all over her body. She was basically in total body pain ever since her accident. Pain rating is from 8 to 10, depending on the part of the body. Then she had 2 series of 20 treatments each with the light stimulation to the eye. You see here the expansion of the visual field, the green, the red and the blue now being almost in the normal range after 2 rounds of treatment. And you see she didn't have any other treatments. Her body pain is almost completely gone. She has a little bit low back pain still. And I believe that we're the first ones to observe that correlation between the visual fields for the colors and pain that has never been written down anywhere, never been reported on. And we've just seen it over and over lifestyle changes like that observed in psychotherapy. People start suddenly, they file for a divorce that was long needed, or they get in better jobs, make more money, suddenly their creativity comes back, they have more friends, and those sorts of things. This is things I've observed that I'm suspecting that psychotherapy and therapy with these instruments is virtually working on the exact same thing in the brain, modulating the chemistry in the brain and allowing people to free out their capacity, their potential. And it doesn't, there's really no qualitative, or no, let's put it this way, no quantitative difference between the effect that you observe by using an instrument or using a therapist. Of course, like the therapy, has other advantages. It makes people more conscious of their growth and so on and so forth. So I don't want to put that down. I'm very much for people being in psychotherapy, but for the right reason. If you want to treat symptoms of an illness, you don't need psychotherapy. You can use any of these instruments and get there quicker, faster, more elegant. And psychotherapy should be used with the only intention of personal growth. It should not be used in my mind as a means to try to achieve pain relief or achieve relief of illness. That's my personal opinion, and I'm ready to discuss it with anyone. There's been no observation that lots of money and time people have been wasted by going to psychotherapy for the wrong reasons. Their reason was they couldn't go back to me for many years and they were so desperate, and then some psychotherapists promise them, oh, no problem, I can get rid of it for you, and then they end up on that path and get very frustrated with psychotherapy because it doesn't work. And with the end effect that people are disenchanted with psychotherapy and give up all hope of getting overwhelmed. Whereas when you can steer people in the right way with relief and being good, and then say, okay, now we're coming towards the end of the treatment, now I think it would be great if you could enter a psychotherapy program in order to work on your personal growth so that you don't recreate those life circumstances that created your initial injury or whatever. And I think that way you're guiding the patient in a much more elegant, efficient way.
What was the exact color and for the paint representation?
Well, this actually, the workup is much more complicated than this. She was actually treated with indigo light in this particular case, and there were some complications along this which I may mention here. Initially, we treated her with indigo light, and she got wonderful response. Got about 50% better, and then I did the mistake because of, based on one of the evaluations, it was suggested that she needed red light. I treated her one treatment with red, and within a week after that, she got a fever. She got signs of spinal meningitis, inflammation in the spinal cord, and we got a white blood count, so she had an infection within the CSF. And we treated her with antibiotic with Septin, and she responded very, very well, and ever since then she's been pain-free. And the point that I'm making here is this, that with the red line, obviously what we triggered was an whole focus of infection that she had in the brain from the penetrating injury that was lodged somewhere in the brain, creating obviously an interference field that caused chronic pain that she had. And by giving her red light, it activated that focus, it broke down the wall, the seal that it had, and it got flushed into the CSF. And by treating it with an antibiotic, it cleared up the whole situation. It was over a year ago, and she's been completely pain-free since. So I should have given you the full story. It was a very interesting case, very fascinating case for myself. But that's how powerful this color treatment is. It can also activate, or neurotherapy is called retrograde phenomenon, that you bring the disease to an earlier stage, or like in homeopathy, you bring it to an earlier stage, which in this case was a very life-threatening situation, which fortunately I recognized early enough. Living in the medical community I lived in, I needed to treat her in my office 3 times a day for 1 week with IV injections, not daring to send her to the hospital because of the legal implication that and little glass vials which are exposed to the particular light frequency, light wavelength and frequency. So I have like 3 different vials with indigo. One has been exposed to the frequency of 9 hertz, which is the typical one. One has been exposed to 15 hertz and up to 18 hertz, which are other frequencies which are possible. And then I put this in down bottles with dark glass and shake it up. And keep those in buckets and keep those. And so now you can understand the idea by using it basically makes a homeopathic remedy with a specific frequency of the color in it. And you can test it and send you a test for it. It seems to be the most accurate way of testing for it, more than you always test.
I have a optometrist that I work with, he's from Sacramento, he uses an instrument called a cicchiometer. To first maps out the visual field and compares the right side with the left side, and also where the visual field is by size. He can determine whether the focus is in the teeth or the tonsils or the brain. So he gets this determination that he has a focus, he'll send me the patient and we'll do a focus examination of his mouth to see where we can find the focus and to eradicate that focus. Then, if that was just a focus in the mouth, then he'll go down to that point.
How has it worked in your experience?
We've only treated 3 patients now, which is really working well because a lot of these people who have these focuses, they need like 5 different pairs of glasses and things. So maybe going to a neurologist and he's never finding anything, but he's getting the lottery and just a little more pair of glasses.
So I'm very glad to hear that, Gary, that there's other people, working with the visual field in other ways, and I'm talking later on because I want to get the address of this guy.
I have 2 reprints on it. I'll give them to you. A fellow named Washburn from Seaside, California, 25 years ago, wrote the first article about that. But he's not there anymore, he's gone.
Yeah.
So.
Well, color therapy has been around since the early 1900s, and there's been the main man here has been Dr. Spittler. Spittler treated just during the years before the war a lot of psychotic patients in a large psychiatric institution with dramatic results. And unfortunately, during the war years, the attention wasn't drawn to that. And after the war was a big area of penicillin and breakthroughs in drug treatment. And he was sort of stumped, his results were stumped in the background by the officials then, by the upshooting pharma industry and stuff. But he wrote some articles with stunning treatments for psychotic conditions and chronic depression with use of light. And now light therapy is of course emerging again, like for seasonal affective disorder, the use of full spectrum white light for 1 hour in the morning, 5 to 6 is the treatment time, with dramatic results in treatment of depression, especially in the area of Seattle area, Washington area. There's now very well research and acknowledged that the changes in the beta-endorphin levels that treatment with white light and ultraviolet light for treatment of injuries and so forth. But there's a whole treasure of potential things here for the future. I just want to briefly point out.
Did you have any success with biofeedback or anything?
I myself am not using biofeedback because we're using hypnosis and they're sort of very overlapping in what they're doing to people. And I know that there's definitely a place for biofeedback. And we have a biofeedback clinic in Santa Fe. I have not seen any dramatic results from it personally, but I know that Chile is using it and some other outstanding people, and they're all saying that they wouldn't work without it. Do you have any experience with it?
No, a lot of the literature recommends the chronic thing.
Yeah, I'll be also always very guarded about what you read and what's recommended. As people tell you what kind of a workup they take people through, because like I said, because of the summation phenomenon, everyone has their little things sort of that they're doing, and they find that it works to a certain degree, and then they promote it, and depending on their own growth. They should have some psychotherapy, everyone should meditate, and everyone should do some type of physical workout routine that includes some yoga type of exercises. And get over the years and time more and more in touch with their body, to listen to their body, to listen to their body, telling them what to do. And people that are in a process involved like this, they don't need any feedback, the machine telling them what their body should be telling them. It's really what it is, sort of, if you can tell whether your buttock is tight or it's not tight. I can tell that my buttock is tight, and I'm just kind of bring my attention there. And by feedback, you got a machine there, so that tells you yes, your buttock is tight and on loose. And my opinion is that I don't want to have any patients in my office that need that type of crutch. I send people straight to the yoga class or straight to meditate and start working on their road, start to get in touch with their body again and living a full life. But I think biofeedback could be a helpful first step.
There's one other thing that I came upon, I haven't worked with for a lot, because I just picked up a book about 4 or 5 months ago called Brain Pathology and Acupuncture. It deals with the emotions of how the body somatizes these conflicts that people have through their upbringing. And I have been using the 5 elements of the energetic cycle using my Mora, but then I use the gem elixirs and different flower essences to balance the elements out, and then at certain times pick out those essences and elixirs as different nations. And that seems to be working with some
I think one of the points that you're making, sort of, in order to treat psychological disturbances, there's obviously many ways to treat that. You can treat the psychological disturbance with homeopathy, especially with the flower remedies. You can treat it with yoga exercises. They're beautiful, powerful exercises that are more effective for the emotional needs. However, in order for consciously growing, I think it's important to involve some amount of psychotherapy to make the things conscious or to give you control over what you can do without. The flower remedy or gem elixir is still a crutch, and ultimately all the things that are in the brain, you can't conquer yourself, you can treat yourself. And same is true for all the other components of pain. I don't want to, but the truth is that any patient with any chronic illness can treat themselves with the highest form of treatment. All we're doing here is discussing the crutches that sort of are somewhat on a lower level. And the highest level of healing, in my opinion, still is the self-healing, which is possible for everyone. However, if somebody is in chronic pain, and that's why I'm specializing in chronic pain, I find often they get so in a rut, and there's such an impossibility for them to conquer that on their own, just look at the left side, you got the structural injury, the electromagnetic disturbances, biochemical changes, and the CNS changes. Symbolized by 4 glasses. If this is heavier than what's constituting the health in the patient, the scale is going to tip and the patient is going to be in pain. In order to bring the scale back, we can start on any of these 4 things to reduce it and give the patient a chance to move back into no pain. And this is my explanation why so many treatments work. And however, because of the exponential curve that any one treatment modality follows, it usually is not the right approach to use one single approach or one single angle, because you're going to get empty one of these glasses. That means, for example, if you take the CNS change with psychotherapy, you're going to get an initial response very quickly, empty the first part of the glass, and then it's going to go slower and slower and slower and slower. And you keep doing it, and you keep doing it, and keep doing it, and the patient just isn't getting in the no pain range. And because of this initial response fast and then less and less response, it's better to combine the treatment modalities, one out of each of the 4 components. Because of the exponential curve that they follow, you get a very quick and dramatic improvement in a patient if you use one out of each treatment, rather than riding one modality to death. And this is my grudge that I got with chiropractors, and my grudge that I got with MDs, and my grudge with dentists, and or with yoga therapists, or with anyone. Just any one therapy is usually working on one at the most on 2 levels. Like manipulation, we know, works both on the structural level and works some on the electromagnetic level, but it doesn't do anything for the immunological changes, it doesn't do anything for the CNS. And so if you don't get home with anything else, I don't want you to get home with this idea. This is true not only for chronic pain, but for any chronic illness. Look at the treatments that you have available in your office, and then get clear on which level they work on. Are they structural? Are they biochemical? Are they electromagnetic? Or do they work on the brain? And then pick one out of each category. And it doesn't really matter so much which one you pick. And if you combine those 4 at the first time when you see the patient, you're just going to see dramatic improvement over and over and over again of people that haven't gotten well otherwise. And of course, like we talk about neurotherapy, also look in the scheme, see where the neurotherapy fits in. It's not the panacea, but it's the most elegant treatment out of one of these categories. And the Punica phenomenon, when you with one injection completely relieve the person's pain for at least 20 hours, it just simply means, this is the cup number 2 here, that cup number 1, 3, and 4 were already fairly empty, and the scale wasn't too far to the side, and by emptying cup number 2, by doing the neurotherapy procedure, you tip the scale over, and that's what the Punica phenomenon is. You observe the same thing with every other therapy. Like, I'm always laughing, like if somebody said, well, I started taking germanium, and since I took germanium, I'm completely pain-free. Isn't that a miracle drug? And the truth is, no, it's not a miracle drug. It was just that in the biochemical changes here, he had a fairly full cup here, and the germanium happened to decrease it enough in that exponential curve to make the difference, and this wasn't all that much out of balance to tip it over into the no pain range. Now, this scale isn't quite right. Often there is a dramatic difference between being just half of an inch over to this side and a quarter of an inch over to this side. Between pain and no pain, there's a dramatic difference in the perception of your own health and what's going on, and people perceive that transition as a very dramatic point. And whoever happens to be there at the right time, if it's a chiropractor who does that one manipulation that tips it over, he's going to be the hero. If it's the neurosurgeon who operates the disc and it tips it over, he's going to be the hero. And if you do the right vitamin, you're going to be the hero. And if you do the right this or that, or the yoga or the meditation, and you just at that right point, you're going to be the hero. But if you want to be the hero consistently, with a large percentage of the patients, you need to keep this in mind. This model of pain is really going to make a big difference. Next slide. This is a composite of 6 patients, and this is my treatment program, and also showing you where the neurotherapy fits in. This is by combining those treatments. You see here at the beginning, start of treatment, I treat the patient with manipulation and neurotherapy. They come in twice a week, and I start them right away on the proliferant injection if it's a neck or a low back pain, or a knee joint, or it's an unstable joint. The manipulation being a component of working on the structural level, the neurotherapy working on the electromagnetic level, and also they're going to get a course with the Downing technique with the light stimulation of treatment right away for a 3-week period. With the light stimulation, there has to be a break of 4 to 6 weeks before doing a second treatment. About towards the end of the proliferant therapy is when I start my B-venom therapy, which has tremendously improved my results. For 4 to 8 weeks, I do it as a routine treatment on any chronic pain patient, no matter if it's a chronic migraine, chronic back pain, low back, mid back, neck pain. Also, I use the same program. And with this, I'm addressing all the 4 components that we said. On one treatment, I'm doubling up. That's the structural treatment. I use manipulation and proliferant therapy together. And with this treatment, we just seen very, very dramatic results and very short courses of treatment that are needed. And as you see here, there's only one treatment that is given past the complete and the pain-free, reaching the pain-free area, and that's the light stimulation. I like to give that past the time when the patient feels subjectively that he's cured with this one. Next slide. Can you focus up a little bit? Just a short lesson on neurology. I showed you on the last slide, you saw where for me the neurotherapy fits in. And I'm sorry I'm taking so much time in getting to that point. But I want to lead you away from the monomanic approaches of riding one modality to death. And it's also true for neurotherapy. Neurotherapy has on its own a success rate of about 60%. If you just use neurotherapy for pain, you get about 60% of people decent or well. 40% you don't get. With this approach that we have, we're way over 90% of our success rates. And this, again, I'm not making them up. I'm reviewing a lot of people. A little bit of neurology here that will also help you to understand one other aspect of why neurotherapy works and where the brain stimulation works. If you look at the bottom here, this is a cut through the spinal cord. This is the pain receptors or nociceptors. They're stimulated. It's not quite on the chart. Pain impulse travels up through the spinal cord into the thalamus, and in the thalamus it gets switched. The pain message gets split up. One goes to the sensory cortex, tells you where the pain is, and one message goes to the frontal lobe, which tells you the quality of pain. Is it devastating pain, or is it sharp, or is it burning, or is it bringing up a lot of tears and sorrow, or is it just a bright pain that doesn't really bother you, and so on and so forth. Now this is the gate control theory. This part can be modulated. That means the decision whether the pain impulse travels up or not is made here on the spinal cord. And fortunately, the pain impulse can be blocked by other chemicals being stimulated here. And this is done through the mechanoreceptors. By stimulating the mechanoreceptors, which mechanoreceptors are the muscle spindles, the nerve endings that tell you where your arm is in space. There are the sensors to touch, temperature, vibration, the things, the sensory organs that tell you whether your muscles are tense or not, whether they're cold or warm, and so on and so forth. If these get stimulated, the impulse also travels up to the sensory cortex, but there's this famous nerve connection you call the interneuron, which leads to the secretion of endorphins here in the same cell, in the same ganglion. And endorphins are the blocking substances. That means there's other chemicals too, but the main ones are the endorphins. If you stimulate the mechanoreceptors, you excrete blocking substances here, and the pain message cannot travel up. Now, mechanoreceptors, how can they be stimulated? Now, the most simple one is exercise. If you're moving your arms and your legs about in space, you stimulate mechanoreceptors, and you have a good chance of decreasing your pain that you're feeling. This is why exercise is important. If you have a TENS unit, any electronic type of equipment that stimulates the body, stimulates preferentially the mechanoreceptors over the nociceptors. That means especially the TENS unit is good because the current travels within this most superficial layer of the skin. This is the layer where all the tactile and sensory organs are that get stimulated. The nociceptors, the pain receptors, are sitting somewhat deeper in the tissue, and if you put a TENS unit on, you selectively stimulate the mechanoreceptors, therefore again leading to an output of endorphins here and pain traveling up. If you inject a scar, now it comes to the neurotherapy, or some of the deeper lying structures, ligaments, ganglia, you usually have in these tissues a preferential increased density of mechanoreceptors. Again, your novocaine or lidocaine stimulating more this mechanism than this mechanism, therefore leading to blocking out of pain impulses. Also, your massage and body work through stimulating of the mechanoreceptors in the muscles tremendously stimulates this axis here. I want you to have a look at this because most pain theories are so complicated and such a forest of information that I spent some good deal of time and years in sorting through